Thank you for joining us today for Psychiatry Grand Rounds. This program is provided by the Michigan Center for Rural Health in cooperation with MSU Psychiatry Department, the MSU College of Human Medicine, and MSU College of Nursing. Before we begin, please remember to keep your mic muted until the Q&A component at the end of the presentation. Please remember to mute your mic after you've asked your question so the signal is clear and other sites cannot hear your conversations, and so that the presenter can answer the question. Handouts are located on our website at mcrh.msu.edu. Click on the education link found at the top, scroll down, find today's date, and there you will find handouts, attendance forms, and the evaluation link. Continuing education is available for physicians, nurses, and social workers. Each healthcare discipline has their own attendance or sign-in form, and everyone fills out the same evaluation. Physicians, please note that there is a new process for you in order to obtain your certificate. Directions are located on the bottom of our website, or if you have any questions, please feel free to contact me. Attendance forms and sign-in forms need to be emailed, faxed, or mailed into the Michigan Center for Rural Health office. The evaluation must be completed online. Physicians, please make sure your site proctor is signing your sign-in sheets. Please complete these forms and your evaluation within 2 weeks or by May 10th. Our speaker today indicates no conflict of interest, and the planning committee did not have any conflicts. There is no commercial support for this program. With that, I am pleased to introduce Dr. Jet Megan, who will be speaking on dementia behaviors. Go ahead.
Okay, so we're going to talk about dementia today, and I'll spend some time talking about various types of dementia and symptoms because they do differ a lot. We'll spend most of the time on this topic, which is managing difficult behaviors, and the shorthand answer to this is mostly it's not medication. So I have no conflicts of interest. Off-label medication use will be discussed, and I have to give credit to Dr. Deb Wagonar, who's my geropsychiatrist in my department. She contributed to this talk. And obviously we're going to talk about older Americans who tend to get dementia more than anyone else. So in DSM-5, dementia is classed as a neurocognitive disorder. And just briefly, you have major and minor neurocognitive disorders, and dementias are classed as major neurocognitive disorders. If you want to call them dementias, that's fine. If you want to call them neurocognitive disorders, that's fine too. So these are just a variety of disorders that either are neurocognitive disorders or a component of which can be neurocognitive disorders. We'll talk about some of them. So the common characteristics of dementias or neurocognitive disorders are really these. So it's neurocognitive, right? So people get cognitive deficits. And of course you get things like memory impairment, aphasias, difficulty speaking or hearing or understanding, apraxias, agnosias, executive kinds of dysfunctions, executive dysfunction being, of course, the ability to think and plan and then carry out tasks. Certainly personality change is a big part of many different dementias and is one of those things that can really cause real problems for caregivers. And of course, social and occupational dysfunction, which often happens relatively early, but not immediately in these kinds of disorders. Prevalence, well, you know, some people talk about the silver wave, which is the increasing number of older folks in the population, and along with that, chances of dementia, and of course the prevalence of dementia increases. So here you got just some statistics on affected populations. So there are a lot of people out there, and they're going to be increasing numbers until we come up with treatments for these kinds of things. So if you're in any kind of setting where you encounter older people, you're going to run into dementias. So, you know, this is the kind of thing you put on billboards. Currently, somebody in the U.S. is diagnosed with Alzheimer's disease every 72 seconds. By 2050, every 33 seconds. Sounds dramatic. Findings consistent with Alzheimer's. So let's talk about Alzheimer's first. So Alzheimer's is a slowly progressive disorder. And when I mean slowly, you're really talking about from the time of diagnosis to death, you know, often in the range of 10 years or so. That's relatively slow. In Alzheimer's being a cortical dementia, so not subcortical, but cortical, gray matter mostly, really you get global losses in things like cognition, the ability to think, planning, executive functioning, certainly language, memory, and visual spatial abilities. and decreased ability to process change. So what that means is these people can become relatively rigid. So now, what you see is, since you can't deal with change and you have a variety of other deficits, what you may see early on in the disorder before you've diagnosed it is people begin to constrict their range of social activities. They begin to do less. And the reason they're beginning to do less is because they can't function in those other environments. And then later on, it becomes apparent to you when other deficits begin to show up that this is a dementing disorder. Now, on the other side of this, what are findings inconsistent with Alzheimer's? Well, remember, it's a slowly progressive dementia. So you don't tend to get severe disinhibition. That would be a frontal lobe sign. And Alzheimer's is not primarily frontal lobe. It is in part, but especially early in the disorder, it's not. So you don't get severe disinhibition like you get with disorders that whack out your frontal lobes. Changes in motor function, that would be a subcortical kind of finding. Deeper areas of the brain, and Alzheimer's is a more cortical disease, so you don't find that. Rapid onset, no. Loss of vision, no, not part of Alzheimer's. Early loss of speech or fluency, no, that comes, but it comes a little later in the disorder. It comes more slowly. You don't have focal neurologic signs, and you don't get muscle wasting. That's just not a part of the disease. And you don't get motor apraxias early in the illness, and apraxia being a difficulty with organizing a motor function, like you might give somebody a shirt and they can't figure out how to put that shirt on. That would be a dressing apraxia. So, here's a question. Mrs. Smith's family noticed that she suddenly has not been able to balance her checkbook, appears apathetic, and cannot figure out how to operate the TV remote. These changes happened suddenly. They just happened overnight. Well, what is this? Well, first of all, remember, Alzheimer's is slowly progressive, so it's probably not Alzheimer's. It's not normal pressure hydrocephalus, because that's a triad of incontinence, ataxia, and dementia. So there's a triad that goes along with normal pressure hydrocephalus. It's not Lewy body, because Lewy body has other symptoms. So this is really a vascular insult. This is vascular dementia. You're getting microinfarcts. You get these sudden microinfarcts, and so you have this, what's classically called a stepwise loss of function. So vascular dementia, dramatic onset, dramatic changes in personality or behavior with the onset of these stroke-like phenomena. Again, they can be microvascular or bigger. Disinhibition if it's frontal lobes. Labile changes in mood. This is what's called pseudobulbar affect. I bet you've seen the television commercials for pseudobulbar affect now. And frustration with word finding and communication. Anybody that has word finding difficulties or communication difficulties, for whatever reason, is going to be frustrated. Now, what if she had Lewy body? Well, the prominent and dramatic finding in Lewy body dementia is visual hallucinations. So, and you'll find Lewy bodies in what are so-called Lewy bodies in the central nervous system, and these people prominently will begin to have visual hallucinations of little people. These are complex visual hallucinations. Along with this can go some motor abnormalities later in the illness that look Parkinson's-like. There's always been this question of whether Lewy body and Parkinson's are related or not, and it's not clear. So early changes in executive functioning, fluctuations in awareness and concentration, these distressing visual hallucinations and delusions, vivid dreams, and this tremor, so frustration over tremor, mobility problems, that looks Parkinson-like, or Parkinsonian. If Mrs. Smith initially presented with increased apathy, perseveration, and socially inappropriate behaviors, such as disrobing in public, what has she got? Well, it's not Lewy body. You know, Lewy body gives you hallucinations. It's not Alzheimer's, because that's longer term. You can get this later in Alzheimer's. It doesn't have the triad of normal pressure hydrocephalus. Now what you got is frontotemporal dementia. Now you've really affected your frontal lobes. So you can affect your frontal lobes via dementia. You can do it by, trauma, whatever. But prominent disinhibition are frontal lobe signs, because frontal lobes really help clamp down on behaviors coming up from deeper structures in the brain. So frontotemporal dementia, executive dysfunction, inappropriate social behaviors, lack of empathy, compulsive behaviors too, and poor judgment. If these come on relatively rapidly, you often have a frontotemporal kind of dementia. So that's just a survey sort of the types of dementia. Now, once you make a diagnosis, like in any deteriorating kind of disorder, What are the treatment goals? Well, obviously maintaining quality of life insofar as possible, maximizing function, stabilizing cognition. We can't really do that, but if you could, that'd be great. We can do a few things about that. Treat mood and behavior problems, and of course, don't ever forget the caregivers. Caregivers have considerable issues in these kinds of disorders. So here's somebody who looks relatively peeved at something. So neuropsychiatric symptoms of all sorts. So here are the kinds of things you see. All of these things. And some of these are more frontal lobe kinds of signs, like verbal sexual advances. That may be disinhibition. So some of these things are disinhibition. Some of these things are irritability from a variety of things and so on. Obviously, and it just bears stating, there's no one necessarily etiology of any of these things. And that's what makes it so difficult to sort of figure out what to do with these things. So, most patients with dementia will get neuropsychiatric symptoms of one sort or another because you're dealing with a central nervous system disorder. And obviously and clearly, these are often reasons for early nursing home placement because you can't handle them in the environment in which they are living for whatever reason. So, any of these kinds of things can be problems. So, meaning of behavior. What I mean by meaning of behavior is, let's figure out where the problem lies. Is this a problem with the patient, with the individual with the dementia? Is it a staff problem? Is it a family problem? Take this in its psychosocial context. What you got to try to do, and again, this can be very difficult, is figure out what is the kind of etiology of this problem. And furthermore, if it's a problem really you locate within the individual, what are they trying to communicate, if anything, through this behavior? Because maybe they are. Maybe they have restricted modes of communication, and acting out in some way is the way they communicate this sort of thing. Models to explain behavior in patients with dementia. Well, obviously you got a biologic model, a biologic/genetic model. It's coming from the central nervous system. It's from these changes, whatever. Behavioral learning models, certainly, and from that flows behavioral kinds of treatments. Reduce stress threshold model. Well, this would be, of course, now you have, to put it in more psychiatric terms, I guess, behavioral terms, your coping skills aren't as good as they were. And you have a restricted set of ways of expressing kind of issues that are problematic to you. And so your threshold for stress is much lower than it used to be. Unmet needs model. Well, you're sitting in bed all day and nobody's getting you up to go to the bathroom. That might be an unmet need. DICE. What is DICE? I will spare you all this. DICE is basically a framework. It's one of these formulaic frameworks to address neuropsychiatric symptoms. Useful because it's formulaic, because you can remember it. So here's what it is. And this comes from evidence, some evidence anyway, and based on expert consensus. So describe, investigate, create, evaluate. This is not unique to dementia. It may be unique to psychiatry, but in psychiatry we spend a lot of time saying to people, whether it's parents of kids or whether it's caregivers of elderly people with dementia or whatever, what happened? And what happened next? And then what happened after that? And what happened right after that? So we want them to draw us a picture of the whole episode of behavior, and that's what you're doing with this kind of model. So play it back as if it were a movie. That's exactly what happened, how did it start, and what happened next, and what did you do, and what happened next, and what happened after that, and what did you do. So you're getting this really fine-grained description of the whole episode of that behavior. It's hard to emphasize how important and how informative that can be. At the same time, it takes time to do that. So you got to sit down with somebody and say, okay, let's describe this. And obviously, the ability of the individual to give you that picture varies. Some people are really good at giving you that kind of historical information. Some people are not. So play it back, describe the antecedent events, the specifics, and the consequences. So, antecedents. How did it start? What was the time of day? Who was present? What was the activity? What was the location? All those things. How did this start out? Use of behavior diary or logs could be very useful. If you can get people to keep logs, behavioral logs, it's time consuming and you got to have somebody who's dedicated to do it, but it's a useful kind of thing. Describe the most distressing part of whatever it was. how does the patient and the caregiver feel about the behavior? So that's important, right? How does the patient feel about it? If you can get that, is important. How does the caregiver feel about it is equally important, right? If it's a loaded kind of behavior, if it's a sexual behavior, for example, people can have all kinds of feelings about it, right?
There's a site that has their mic unmuted. Can you please mute your mic? Hello? There's a site that has their mic unmuted. Can you please mute your mic? Hit by hitting *6 or making sure your mic on your Polycom is muted. Thank you.
All right. And safety issues, obviously very important. So there are some tools to assess these kinds of things. There are these kinds of tools which you can look up. And they're all okay. None of them is necessarily a whole lot better than any other. But if you want to use one, pick one. Patient considerations. Okay, so now if you got the locus of the behavior, let's say, in the patient, what's that do to? Well, obviously, one thing to think about is medication side effects. One of the things we always think about, especially in elderly people, is anticholinergic kind of medications. They're going to dry them out. Or in guys, give them urinary retention. Obviously distressing. So that's just one example. But almost any medication can cause kind of problems. Think about benzodiazepines. Benzodiazepines disinhibit people. And maybe it's as simple or as complex as that. Certainly pain. Always think about delirium as an issue. Delirium is a change in sensorium. And we always think about delirium in a hospital where people are pulling their lines out and getting up to walk around at night and that sort of thing. But you can have much less obvious kinds of deliria, certainly at home or in a nursing home setting. And it's worth thinking about that. Functional limitations that may be frustrating to people, other medical conditions, psychiatric NPS, psychiatric neuropsychiatric symptoms, which we'll talk about. Just the severity of the cognitive impairment as they get more and more impaired. Poor sleep hygiene, which we'll also talk about. Sensory changes. A classic kind of sensory kind of issue is you got somebody who's 85 and they go into the hospital for a colonoscopy, say, and you take their glasses off and you take their hearing aids out and you put them in a little bag under the cart, and then you give them anesthesia. Now they wake up and they got sensory impairments because they can't see or hear much. You think they could get delirium in that setting? Absolutely. And it might be as simple as giving them their glasses and their hearing aids back. Fear, loss of control, boredom, all those kinds of things are problematic. Caregiver considerations. So caregivers are under considerable stress in these kinds of situations, right? Because you may be responsible 24 hours a day for somebody's care. I don't care how old or young they are. I mean, think about having a newborn. Well, that's a great event. But do you think it causes stress in the parents? Yeah. The saving grace is infants develop and they begin to change and they begin to be slightly less dependent over time. If they didn't, it would be a real problem. So what's the quality of the relationship between the caregiver and the patient? Maybe it's a spouse, maybe not. Maybe it's a cousin or somebody that's drafted into doing this. What are the caregiver expectations? How much time off do I get? When do I get time to myself? Attributions like, they're just doing it on purpose to be irritating. Maybe that's true, maybe that's not so true. Caregiver stress, caregiver stress, caregiver stress. Huge, huge issue. Nobody can handle these kinds of things alone. I just make that as a blanket statement. You just can't do it. So you got to have relief. You got to have other people around to help. And over or underestimation of patient abilities. Well, they can do that themselves. They can't do anything by themselves. Either one of those can be problematic. What's the cultural context? We live in a multicultural society, as much as some people don't want to think that. But, culture matters a whole lot, and cultural attitudes and so on are very, very important. And maybe, these kinds of things, people are embarrassed to talk about stuff. They don't want to let other people know they're having problems because that impacts upon their view of themselves or their fear of other people's view of themselves, or it's just embarrassing to talk about. They may not even tell you as the medical caregiver. How about environmental considerations? Too much stimulation. Too much stimulation can be good or bad. Often it's bad. Clutter, noise, people, all those things can set people off. How about understimulation? You're sitting around all day doing absolutely nothing. That can set people off too. What's the balance there? Well, I don't know. It's different for each person. Difficulty navigating the environment. So a simple example of this is, the 85-year-old guy who gets up at night and can't find the bathroom. And he's ending up urinating in the potted plants, which upsets everybody. Those kinds of things. Simple way to deal with this maybe is to put signs around the house, at least earlier in the disorder. Bathroom. Might work. You should try those kinds of things. Lack of a predictable daily routine. Of course, as you're getting cognitively impaired, routines get incredibly important. Lack of pleasurable activities. Again, if you're lying around all day doing nothing, not so good. Responding to physical problems. So we touched on this, but of course, medications, all kinds of side effects. And, older people in this country are way over-medicated. I mean, people bring in their bag of 20 medications. First of all, I challenge anybody to take 20 medications appropriately every day. I don't think you or I could do that. 2, you think there could be drug interactions? Almost inevitably there are interactions if you got 20 medications. And 3, what about side effects? All those things are problematic. It's amazing to me. Managing pain appropriately is another issue. And that's, of course, a big deal these days, talking about opiates. But you got to know people are in pain and you got to figure it out. Treat infection, dehydration, constipation. Constipation is a big deal in this kind of population. You just got to be aware that those things are problematic. Optimize the treatment of any underlying psychiatric conditions. I'm a psychiatrist, of course, I would say that. Sleep hygiene, sensory impairments. Well, we talked about sensory impairments. We'll talk about some of these other things. Work with the caregiver. Really, please, work with the caregiver. Provide caregiver education and support. Communication. Can you help the caregiver communicate with a patient who may be impaired in terms of their ability to understand or to communicate back? Create meaningful activities for the patient, simplify tasks, and so on and so on. Working with the caregiver, these are just mechanisms that are out there for caregivers to get more information and so on about stuff. Environmental interventions, right, ensure the environment is safe. Tripping, lots of older people fall, either because of deconditioning or because of medications, right? There's great data that shows that benzodiazepines are involved in falls all the time. So ensure to the best of one's ability, ensure the environment is safe. Simplify in the environment. As you get more cognitively impaired, you cannot deal with complexities. And enhance the environment in terms of their ability to understand what's in the environment, what's going on, and pleasurable kinds of activities. Specific interventions, well, hearing voices, right? Sometimes hearing voices is a phenomenon related to your inability to hear. And so central nervous system begin to generate random noises or even voices. Determine whether the voices are a threat to safety or functioning. Sometimes hallucinations really are auditory hallucinations, and then you got to deal with them. Wandering, right? Are there triggers for wandering? Identify them, some identification on the person, right? If they're wandering out in the street, it's really helpful if somebody finds them to be able to identify who they are and what's going on. Exercise can help, right? So they can be sleepier at night. They may not wander. Nighttime wakefulness, sleep hygiene, which we'll talk about. Eliminate contributors, right? Noises. If you're in a nursing home, it can be noisy even at night. A variety of things. Eliminate caffeine or other stimulants. I see a lot of people. I don't see elderly people so much, but the secret is I'm really a child and adolescent psychiatrist giving a dementia lecture, but it's okay. But, we see lots of kids who don't sleep at night, and you say to the parents, well, what are they doing? Well, they're napping for 3 hours in the daytime. Well, that might be a really good reason why they're not sleeping at night. Maybe using a nightlight is important. Nighttime respite for the caregiver. Don't exclude the possibility that some older people are tech savvy and they're on their phones at night, right? And there's good data to show that screens, computer screens and so on, blue light will suppress melatonin production. So if they're up at night and they're on their screen, that blue light can suppress melatonin production and keep them up. Repetitive questioning, calm reassurance, touch. Touch is great. I happen to be a DO, osteopathic physician. So, you know, we do various kinds of manipulative therapies, and touch is just a great thing for people. Structure daily routines. Again, structure. Distraction. Meaningful activities. What's a meaningful activity? Well, you know, I actually know of a situation with a guy who was a carpenter, and he became demented. And what they did, you know, some really smart physical therapist or activity therapist in the nursing home gave him wooden blocks and a variety of things to work with. And he began to work with it. And he spent a lot of time during the day doing simplified kind of tasks that he kind of knew from his previous career. Aggression. If you can modify the cause, obviously, whatever it is. Warn caregivers. Talk to caregivers about aggression and how you deal with aggression. Self-protection strategies. Get rid of dangerous stuff they can throw, you know, whatever in the environment. Environmental changes. Food is great. Food is great. You know, in a psychiatric setting, we use food a lot for people who are agitated. You want a cup of coffee or something. It kind of calms people down. Ambient music, visual reminders as prompts, because a simple visual reminder might be better than a verbal reminder. Opportunities to wander safely. Can you set up an environment where they can just walk around? Simulate natural conditions. This is really important. So you got nursing homes that they're sterile and they're like deserts. Really, you got a hallway and you got nothing in the hallway. You got other nursing homes. Go over to, like in Lansing, if you go over to Dobie Road, which is the county nursing facility, it's great because they got an atrium with plants in it. They got plants around and so on. If you can, you know, normalize the environment, that is, simulate a natural environment, that does a lot to decrease agitation. It's really remarkable. And that's the same thing, decrease the institutional appearance of the facility. Psychological issues. Well, control issues are important. How much in control are you of your environment? If you're not in control of your environment, you don't like it. How much control can you give people? How much autonomy can you give people? People don't like it when their ability to function independently decreases. Now, that's an inevitable part of the disease, but you got to help them through that. What choices can they make? You know, unfinished business, unresolved family issues. Sometimes that drives people. Losses of all kinds of things. So loss of independence, that's a loss. Losses of family, friends, finance, resources, right? You can't do a lot of the things you used to. Family may be around, but maybe they're not right there. And of course, fear of the unknown, a huge problem. Even in a non-dementing kind of setting, older people begin to lose function, and so that loss of function is a loss, and the loss of independence. You're used to walking every day 3 miles. You can't do that anymore. That might be really important to you. So in any of these settings, you got to help the patient accept the lost role. Remind them of abilities that remain intact, try to maximize those, help them foster new roles, work on feelings about dependency, those kinds of things. And then you've got to evaluate, right? So if you make an intervention, you've got to evaluate the intervention. Has it been effective? If not, you dial back and say, okay, we did this. What's wrong with this that it didn't work? Are there unintended side effects? Maybe there are. What do you do now? You know, should we make a further change to the environment? So a lot of these are very iterative. Don't expect the first thing you do is going to be the answer necessarily. So you got to make iterative changes over time. Well, this takes a lot of input from people. Depression. So now we're getting into these neuropsychiatric disorders. So depression is a huge issue in anybody who loses function, essentially. Can be a big issue. Secondly, there is this phenomenon called post-stroke depression. So if you have people with real CVAs, you know, CVAs are identifiable with lateralizing neurologic signs, or if you get microvascular kinds of stroke phenomenon, depression can be an accompaniment to this. So in this list, which statements about depression are most accurate? It's almost always reactive. Well, no, it's not almost always reactive. Often it's a neurobiological phenomenon. And anyway, any psychiatric disorder is a combination of neurobiology, and environment. None of them are one or the other. Depression occurs early in the disease process. Well, sometimes yes, sometimes no. Antidepressants are not effective. Not true. Antidepressants can be very effective. Depression can occur at any point in the disease process. Absolutely. And it has a high prevalence. So maybe a quarter of people with dementia can be depressed, at least with Alzheimer's. Any point in the illness. And we used to talk about masked depression. We don't talk about masked depression so much anymore. The symptoms are there. It depends to what you attribute them. That's the issue. You can say apathy. Well, apathy, that's just the disease process. Well, maybe it is. Maybe it's a manifestation of depression. So, assessment. How do you assess depression in somebody who's got cognitive impairments? Well, it can be very difficult. But certainly caregivers can sometimes tell you. Caregivers can say, he's depressed. I know him or her. And this is really, I've never seen this. He's depressed. Okay. Self-report is often not accurate because of cognitive issues or denial or a variety of other things. Look for behavioral changes. The Cornell Depression Scale, Cornell Scale for Depression and Dementia, is a pretty good one to use because if you don't think of all the symptoms, the scale will think of all the symptoms for you. So it's not bad to use that as a rating scale. So it has mood-related signs. Are you depressed? Do you feel down, sad, that sort of thing? Or to the caregiver, do you think, your father is depressed? What's that like? Well, I know he looks sad all the time. Those kinds of things. Behavioral disturbance, physical signs, cyclic fluctuations. It may be that they're better in the morning and worse during the rest of the day. Ideational disturbance. Ideational disturbance is really cognitive. Are they more negative about things? If you're depressed, you see everything through a depressive filter. So nothing's good anymore, or many things that were good just aren't good anymore. You don't enjoy things much anymore, and a lot of negative ideation about things. If you're going to treat depression, choice of medication, well, selective serotonin reuptake inhibitors, Prozac, fluoxetine, Zoloft, sertraline, a variety of others. SSRIs are pretty good. Paroxetine you may want to stay away from. Paroxetine is what? Can't remember the proprietary name. Whatever it is. You may want to stay away from because it tends to be slightly more anticholinergic. That's not so good. And it does tend to have some, upon withdrawal, you can have some withdrawal kinds of effects. So we tend to stay away from paroxetine in an older population. You can certainly use SNRIs, selective norepinephrine serotonin reuptake inhibitors, the venlafaxines of the world, which is Effexor, a variety of others. If you use one versus the other, I don't care so much. They're probably both reasonably effective. Tricyclic antidepressants you can use, but they tend to have a lot more side effects. MAOIs, again, you're probably going to not use TCAs or MAOIs as first-line drugs, or even second line. You're maybe third or fourth line, because they just have many more side effects and problems. Augmentation. In geropsychiatry, stimulants are used a lot. So Ritalin which is methylphenidate, dextroamphetamine, Adderall, that sort of thing, frequently gets used in low doses. Antipsychotics can be used to augment antidepressants. I would be really, really careful in an elderly population for reasons we'll talk about. People with central nervous system compromise. Certainly non-drug. ECT gets used a lot in depression in older folks when it's quite severe. And ECT, is the most effective treatment we have for depression, bar none. A light box, you have seasonal depression, that sort of thing. One of the things I would say, which is a huge point, is when you're using these medications in older people, think about tiny, tiny little doses. I mean, sometimes it's really a whiff of antidepressants. Sertraline or Zoloft, sometimes 25 milligrams does it. In regular old adult population, or even in a younger adult or adolescent population, we'd be using 125 milligrams, 150, 200 milligrams of sertraline. In a very elderly population, sometimes 25 milligrams does it. So these really little micro doses can be useful. There it is, start low and go slow, at least a third of the adult dose. Complete antidepressant response takes longer. We talk about 6 weeks in a kid or an adolescent or an adult population. In an elderly population, it may be, 8 weeks, 12 weeks, that sort of thing. How long is long enough? Well, we don't really know, but, if you want to go, I would encourage you to go at least 8 weeks or so. Efficacy, we don't have great data on this. So a Cochrane meta-analysis from 2012, sertraline, that's Zoloft, fluoxetine, Prozac, efficacy, weak. Some individual clinical trials, modest efficacy. So, what can you expect? You can expect it to work on some people and not a lot of others. That's kind of the best we got. Agitation, a big deal, right? We all know this. Are there specific patterns of behavior? Are there specific triggers? So again, you got to go through this movie kind of thing. How did it start? What happened right before that? What happened next, and what happened next, and what happened next? So you need a real fine-grained kind of look at what happened. Comprehensive evaluations, right? Same as for anything else. Pain, diuretics, constipation, right? They can't get to the bathroom. Sensory loss, disinhibition. There's the benzodiazepine issue. Psychosis or depression. Try to target specific behavioral interventions. What's the intervention you're going to try? And you got to work with caregivers. How can the caregiver carry out this specific intervention? And of course, there's always pharmacology. You really do want to try. I think most people knowledgeable in the field, almost everybody would say, try the behavioral interventions before you try the pharmacology. Unless you have a real target. So you say, yes, I know he's depressed, because he's more apathetic, he's got negative ideation, he's crying. Those are target symptoms. So if you can define target symptoms, not just depression, but target symptoms of depression, by all means use an antidepressant. Now you may say, I really know this is depression, or you may say, he's got these things that look depressive, like I'm not sure, but at least I got symptoms I can target. Let's try the antidepressant. See, that's perfectly reasonable. Medications to avoid, benzodiazepines, because they're disinhibiting. Narcotic analgesics for a whole bunch of reasons, because they can be disinhibiting, because people develop dependency, because they cause constipation. So on hypnotics, because they don't work that well. They don't even work that well for sleep. Look at the Cochrane analysis, meta-analysis of hypnotics of all sleep medications. And again, they can be disinhibiting, or you can cause, they can be slightly depressant. You can cause things like deliriums. Antihistamines, antispasmodics, tricyclics, try to stay away from those. First-line drug therapies, you can try SSRIs again, because sometimes SSRIs have this quality of decreasing agitation, decreasing irritability, and thus sometimes decreasing aggressive kind of agitative behaviors. They have a low propensity for causing problems, so the risk-benefit ratio is not bad, so try them. Cholinesterase, anticholinesterase agents, again, that we use to promote cognitive function. You can try them. Sometimes they may work. Be aware they have some side effects that can cause problems. Low-dose trazodone, you can try that. Certainly carbamazepine and valproate, the latter two, of course, being anticonvulsants, or in psychiatry we call them mood stabilizers. They can be helpful, but again, they got side effects. And, if you're running out of options, those would be things to try. Dextromethorphan, Quinidine. Sometimes works. And again, it's got a lower sort of risk. So the risk-benefit ratio is not bad, so you can try that. And, you get decreases in agitation, and sometimes you can get increased levels of good behaviors. You're looking for those. Here's the KD-AD trial, antipsychotics, neurocognitive disorders. Not that encouraging, really. And then if you look at the bottom here, 63% of antipsychotics are discontinued at 12 weeks, 83 discontinued at 36 weeks, lack of efficacy or side effects. That parallels what you see in schizophrenia, in fact. Nobody likes taking antipsychotics. And even in schizophrenia, where we know it's more helpful, they discontinue the medications too. So what I'm building a case for here is be very judicious in your use of antipsychotics. So adverse effects of atypicals, atypical antipsychotics, second generation antipsychotics for neurocognitive disorders. Pretty big trials, pretty big set of trials, medications they used, and significant risk for a whole variety of things, including sudden death. We've known that for a long time. So, antipsychotics, the situation with antipsychotics is kind of, if you think they're psychotics, so if you think they're psychotic, for sure use it. If they're not psychotic, use it if the behavior is really severe. Otherwise, try to stay away from them. Use them sort of as the last thing you try. Antipsychotic use since the black box warning. Well, that didn't do much. Lots and lots of people are still on them. So here's the APA, the American Psychiatric Association consensus guidelines. Kind of what I said, use only when the agitation or psychosis is severe, dangerous, or distressing. Risk benefits, talk with legal decision makers. Yeah, avoid long-acting antipsychotics. Don't give them injectables because they're long-acting. If you got a problem, it's going to be there for a long time. Taper and withdraw if no response in 4 weeks. So, unlike the situation with antidepressants, 4 weeks is probably a long enough trial. Here's the sleep disturbance issue. Sleep disturbances are a big deal. Does sleep efficiency increase with age? Clearly not. Do they get increased sleep latency? Clearly yes. Do they get more good REM sleep? Clearly not. Increased stage 3 and 4 sleep? Nah, not really. So the problem is, as you get older, it can be harder to go to sleep. And you have, in fact, decreased sleep efficiency and decreased REM and so on. There are arguments about whether you need less REM in elderly people or not. But overall sleep deficiency decreases, circadian rhythms become phase advanced. Increased sleep latency and nighttime arousal, reduced REM sleep, decreased stage 3 and 4 sleep. So phase advance, they go to sleep later, and thus they wake up later, and so on. Causes. Well, certainly we always look for things like obstructive sleep apnea. Restless leg syndrome, absolutely worth looking for. Stimulants, right? Alcohol, caffeine, and nicotine can be a real problem. Lack of exercise, there's the daytime napping issue. Certainly pain, getting up at night to go to the bathroom, and maybe you can't find the bathroom. Maybe it takes you too long to get to the bathroom, and certainly medications that can either make it difficult to sleep or make you sleepy. Wellbutrin, bupropion, infamously is a medication in psychiatry that causes difficulty sleeping, for example. Non-pharmacologic strategies, always the best. So sleep education, certainly things like CPAP for sleep apnea. Sleep hygiene, we talk to everybody that has sleep problems about sleep hygiene, unless it's obviously obstructive sleep apnea. But I don't care what age. We talk to kids, adolescents, adults, everybody about sleep hygiene. Caffeine and nicotine, avoid those, right, for at least 6 hours prior to sleep. Caffeine's got a half-life of, probably around 12 hours. Avoid alcohol at bedtime. You would think not, but avoiding alcohol turns out to be good. Don't eat a heavy meal. No heavy exercise. Minimize noise, light, and heat, right? Encourage daytime exercise. Don't let them nap during the daytime. All those kinds of things. And try the sleep hygiene measures because despite what the pharmacological houses will tell you, the drug companies, we do not have good medications to help people sleep. And anything that really puts them to sleep, like antipsychotics or whatever, gives them real side effects afterwards. Warm glass of milk, tryptophan, pretty good. Melatonin, yeah, those things may or may not work. Avoid benzodiazepines and non-benzodiazepine hypnotics. Avoid hypnotics. All right. So here is a selection of older people for your viewing pleasure, I guess. And we'll stop there.
Okay. So we'll open up lines for questions and comments. So if you have a question, please state your site name first and then ask your question. So are there any audio or video sites that have any questions or comments?
Regency at Canton, just wanted to say thank you. It was an excellent presentation.
Pleasure.
Are there any other questions or comments?
Perfectly fine to wind up early.
Mackenzie Health System.
Go ahead.
Yesterday on the news, it said the number one leading cause of death in America was obesity. And recently I've been seeing some links between high blood sugars and dementia. Could our physician comment on the increase of sugar and perhaps and dementia?
So the number one cause of death is obesity. You know, it depends how you cut it, right? Because when you say obesity, what you really mean often is cardiovascular disease, diabetes, et cetera, et cetera. So that depends. So the problems you get, you certainly get metabolic syndrome. Now in psychiatry, we think about metabolic syndrome being caused by antipsychotic medications. But for other reasons, you know, you develop obesity, you get metabolic syndrome too. So now you got hypertension, you got probably abdominal obesity, maybe you've got type 2 diabetes. And the other issue is obesity probably causes general inflammation. And those inflammatory processes are bad for you, and they lead to all kinds of things, including perhaps diabetes and so on. So, you know, what can you do about those? You know, the usual things. The problem in dementia is, you know, you're not likely to get a lot of self-control in terms of eating and so on. So you've got to try to regulate via the environment. Certainly medications like metformin and a variety of others can be used, certainly control their blood pressure, but you're now into really secondary prevention and trying to modify what risk factors you can. And that's, you know, that's probably about all you can do. We don't have a good treatment for obesity, except maybe surgery, and that's not going to happen in these folks.
Any
Thank
other
you.
questions? Okay. Any other questions or comments?
Hi, I work for a hospice program, and what I'm finding is sometimes with people with dementia at end of life who have been relatively mean in their demented state, at the end turn nice, and then the opposite as well. People who have dementia, who may be nice, then turn nasty. Have you ever had any experience with that, doctor?
Well, so right at the end of life, you know, that can be, sometimes that's a neurological phenomenon, a central nervous system phenomenon. You get you get an infarct in the right place, and you get either happier or not so happy. That certainly happens. So that's one. You know, certainly psychosocial issues, right? You're increasing dependence, the awareness of death, all those things. It can be, again, it's differential diagnosis. It can be any of those things.
Yes. Thank you.
Do we have any other questions or comments? Okay. Well, if you don't have any other questions or comments now, or if you think of them later, please feel free to email them to me, or you can indicate them on your evaluation and I'll send them along to our presenter. Thank you for joining us, everybody, and have a great day.
Thank you all.